Is now being recorded.
Hello? Hello? Good afternoon. This is Wendy Nelson from the Office of Behavioral and Social Sciences Research here at the National Institutes of Health. I just wanted to tell you that we will be starting in approximately 5 minutes, and we ask that everyone mute their telephone so that we don't end up with feedback. Thank you very much. Can everyone please mute their phone? Good afternoon. This is Wendy Nelson, and I'm very happy to welcome the NIH Adherence Network's first of our Distinguished Speaker Series. I am the co-chair of the NIH Adherence Network, which represents about 17 institutes at NIH whose goal is to improve adherence research in any way we can. Our speaker today is here on behalf of the Agency for Healthcare Research and Quality, or AHRQ, which is similar to pronounced to Noah's Ark, who is a recent addition to our network. And I'll introduce today's inaugural speaker in our Distinguished Speaker Series. AHRQ is an independent HHS research agency with the mission of improving the quality, safety, effectiveness, and efficacy of healthcare in the U.S. Its broad portfolio of health services research and dissemination includes support of the ongoing public adherence campaign of the National Consumer League, known as Script Your Future. AHRQ also sponsors 7 Centers for Education and Research on Therapeutics, or as they're more commonly called, CERTs, who are doing innovative research related to medication adherence, both as independent centers as well as collaboratively. Their collaborative focus has centered upon what they term patient-centered medication management, so as to deliberately and pointedly avoid the negative connotations for patients of the term adherence. Our speaker today, Dr. Bruce Lambert, is a professor of pharmacy at the University of Illinois at Chicago and the principal investigator of the CERTS Research Center there. He was instrumental in framing the unique patient-focused approach that the collective CERTs are developing in partnership with other organizations. Dr. Lambert is a social sciences scientist and health services researcher with a Ph.D. in speech communications, who since 1996 has focused on improving the quality and safety of medical care, especially as it relates to prescribing quality and medication use. Dr. Lambert dislikes long introductions and asked us to refer you to your favorite search engine if you want to know more about his accomplishments and publications. We thank AHRQ for nominating and sponsoring Dr. Lambert's participation on our Distinguished Speaker Series. We look forward to his thought-provoking presentation on ethnographic work that shows an inherent contradiction between patient-centeredness and medication adherence. With that, I give you Dr. Lambert.
Thank you, Dr. Nielsen. Hi, everyone. My name is Bruce Lambert from the University of Illinois at Chicago, and it's a pleasure to have some time with you today. I have a lot to say today in a relatively short time to say it, so forgive me for speaking quickly and moving quickly through my large number of slides. Next slide, please.
Can you just read that?
Oh, yes, and please know that there is a Twitter hashtag, #NIH Adherence, if you want to submit questions, and we will eventually respond to questions submitted to that hashtag. So thank you. Next slide. There's a picture of me, since you don't see me live, that is a semblance of me. Next slide, please. And there's the title of this talk, Patient-Centered Adherence is an Oxymoron, Self-Regulation of the Lived Experience of Chronic Illness. So what I want to talk about is how the term patient-centered adherence doesn't make that much sense to me, especially from a particular point of view that I want to develop and explain today. Next slide, please. So as a preface, I want to say that the presentation today is more like an editorial rather than sort of, if you draw the analogy to news, this is more like an editorial, rather than a news story, in the sense that I'm not going to be presenting an evidence-based review of adherence research. I mean, many people on the call will be familiar with the evidence. That's not what I'm going to do. Instead, I'm going to editorialize about a particular point of view, a particular way of thinking about adherence that you might not have thought about before. I want to invite people to think about the experience of chronic illness and the relationship between chronically ill people and their medicines a way that you might not have thought of things before. And so I'm focusing not on adherence per se, but on the experience of illness as it may relate to medicine. I'm a social scientist. I often speak to groups of clinicians and have to apologize, but today I will make no apologies. One unusual thing about the talk I'm giving today is that it really derives more from what you might think of as a scholarship of teaching. What I'm going to talk about today is a point of view I've developed over about 20 years of teaching this material. I've written a few articles about it, and I can try to make those references available at the end for people who want to read more. But mostly this is the point of view I developed in teaching, both pharmacy students and graduate students in pharmacy administration. And the conclusion that I'll eventually arrive at is that a fundamental problem in all this work on adherence is that we've got the wrong implicit model of people with chronic illness. Yeah. What it's like to be chronically ill, what it's like to be a person with chronic illness. Kind of biomedical caricature of what it's like to be sick on people that doesn't fit. And so I concept these images in terms of, tongue-in-cheek, biomedical man versus what I call reality man. I'll get to that towards the talk. And I have a kind of maybe surprising conclusion that I don't think physicians are the answer to this adherence problem for reasons. So an overview of the main points I want to make. I think we need to have a good ethnographic, qualitative account of chronic illness. And the one that I prefer is called the trajectory model. It comes from Juliet Corbin and Anselm Strauss. Anselm Strauss, the famous sociologist. Corbin wrote a book in the 80s about the trajectory model, which influenced me a lot. I think it offers the most authentically patient-centered description of what it's like for a person with chronic illness. It uses grounded theory method to arrive at that theory, and that's what I'll be talking about today. The main point of that theory is that, previous slide, please.
Please put yourself on mute.
The main point of that theory is that the fundamental motivating factor for people who are chronically ill is to maintain the stability of this thing they call the BBC chain, which is the link between body, biography, and conception of self. And I'll talk about that linkage in more in length as I get to it in my talk. But this becomes a central way of thinking about chronic illness from the point of view of the trajectory model. And so what follows from that is that decisions about medication are decisions about identity and biography. They're really decisions about what sort of person you want to be and how you want your life to unfold. And so once we realize that the motivation for chronically ill people is to the linkage between body, biography, and conceptions of selves, so that's the goal. But then we have to realize who are these people trying to achieve this goal. And there I think we need an accurate descriptive model of human rationality, decision-making, cognition. Not a normative one about how people would be ideally, but how people actually are in their limited ability to make decisions with their limited attention span and memory and reasoning powers. So we eventually arrive at this basic hypothesis that regimens that stabilize this BBC chain between body, biography, and conceptions of self, that facilitate this biographic work, this rewriting of the story of our lives, and that produce positive identity transformations, these regimens will be integrated into self-regulation. Others will not. And in a nutshell, that's the whole talk. Now, next slide. So we all know that adherence is often abysmal, often hovering around 50% across a wide range of chronic conditions, sometimes a little bit better, sometimes a little bit worse, and that generally speaking, interventions to improve adherence have not been sustainably successful at improving rates of adherence very much over the long term in real-world practice situations. And this is in spite of hundreds of millions of dollars and thousands of publications on the topic. Next slide. And we're not really sure why. So it's a very frustrating situation scientifically. This is in spite of 74,000 articles in PubMed when I ran a search on, I think, the word medication adherence, the phrase medication adherence, as I put this talk together. So it's 75,000 articles, all amounting to very poor understanding still of why people don't, quote, adhere to their regimens. So this, to me, this points to something fundamentally wrong in our conception of what's going on. If we really had the right basic framework, then you would think we would have learned something more from 74,000 articles. Next slide, please. So this adherence makes health professionals look bad and feel foolish and ineffective and irritated and frustrated, perplexed. Here, patients come to see health professionals, often at great expense, and endure great discomfort to be diagnosed and to have a regimen designed for them, and then they leave the office and simply don't follow it or modify it in dramatic ways. And this leaves professionals pulling their hair out, not understanding what's going on. Next slide, please. The general consensus from health professionals, from people who are biomedically oriented, experts, as we would think of ourselves, we think patients would be much better off if they would just do as they were told. We look at the evidence from the randomized trials, from the big observational trials, and we think, why don't they just do this? It would obviously benefit them. That's our impression. And yet they don't, and so we're left in this quandary. Next slide. So lately, as people are very frustrated with this, so they've been trying to strive to come up with new answers. So the latest answer, a long litany of new answers, is that maybe if we're patient-centered, that will help. But it's not at all clear what that would mean. So, for example, because of PCORI and the Patient-Centered Outcomes Research Institute, because of sort of the zeitgeist, sort of being patient-centered is the thing to do these days, and no matter what we do, a lot of us are calling what we do patient-centered now. So it's not clear even what that phrase means, but I want to explore what it might mean in relation to patient adherence and whether that makes any sense, or whether we can give new meaning to this term patient-centered. Next slide, please. So I don't think it means patient in the center, us looking at them through a biomedical lens. That's one thing I don't think it should mean. I think that's what it does mean too much of the time, but I don't think that's what it ought to mean. Next slide, please. So that's this. This is, could you clear that, please? So this is how patients feel. They feel like they're in the center, lots of people looking at them, multiple providers. And next slide, please. And this is what they really feel like. They feel like they're the bullseye. They don't feel like they're at the center of concern necessarily, but they feel like they're caught in the bullseye and they're vulnerable to harm. Next slide, please. So what we really like is to see the world through the patient's eyes, rather than, and hear the patients in their own words. Next slide, please. So this is, just a pictorial description of what it ought to be like. We should try to decide, but ideally the patients are not going to be always undergoing surgery or some procedure, which is what we see here. Most of the time, if you put a camera on most patients' heads, they would mostly be, you'd see them at home. That's where chronically ill patients spend most of their time. But I just wanted to depict this idea of seeing broken patients' eyes. Next slide, please. So I think we need two kinds of understanding to help patients self-regulate more effectively. And notice I use this term self-regulation. I think that's the best way of thinking about what patients do, thinking about adherence, which is some kind of obedience or something like that. I think this is completely the wrong way of thinking about it. I don't think it jibes with what people tell us when they describe their lives when they're chronically ill. And in my abstract, I tried to use the word we and us because, of course, we're all patients. If we're lucky to live long enough, all of us will be chronically ill. So I'm going to try to keep using the word we and us. So if we want to understand ourselves when we're chronically ill, we need to think of this term self-regulation rather than any other more biomedically oriented term like adherence, where we're kind of following orders. What we're really doing is kind of improvising all the time, trying to make our lives as good as we can. Next slide, please. These two kinds of understanding we need are, one, an accurate ethnographic account of what it's like to be chronically sick. And here I think the trajectory model and all the work that stemmed from it, especially the work of Kathy Charmaz and Peter Conrad and David Karp, and mostly sociologists who have done ethnographic studies. And if you email me, it's easy to find me on the web. I can send you the syllabus to my course, which has a bunch of these readings. There's dozens and dozens and dozens of ethnographic studies of people with chronic illness and in relation to their medicines, and they paint a very coherent picture of what it's like to be chronically ill, but it doesn't look anything like the biomedical image of the way we think of patients. And second, we need an accurate model of human motivation, cognition, choice, and decision-making. So the way I look at it, since World War II, there's been sort of a revolution in social science. But mostly it's not penetrated into the world of biomedicine at all, or just at the periphery. And these two revolutions are having a much better ethnographic understanding of what it's like to live with a chronic illness, thanks to Anton Strauss, what it's like to live with chronic illness, and a much better model of human motivation and cognition and so on, thanks to sort of modern experimental psychology. So the ethnographic account tells us what motivates chronically ill people, what goals they pursue, and the model of motivation, cognition, et cetera, tells us what kind of resources people have to pursue those goals. And we need both, I think, to understand what people are really doing when they self-regulate when they're chronically ill. So first, I want to talk about this ethnographic description of chronic illness. Next slide. So here's a bunch of terms. Ethnography. This is, trying to understand the culture from the inside, trying to understand the meaning of experiences from the point of view of people who are having those experiences. Now, we normally think of anthropologists and pip helmets going to Indonesia, and that's what we think of as ethnography. But in fact, you can take an ethnographic approach to any topic, including chronic illness, and that's what Anselm Strauss have done. And they use the method of grounded theory, which normally involves very, very long-term, repeated, long-form interviews and qualitative data analysis, interviews of people over years. to try to understand the experience of chronic illness as it's extended in time, interview-based, and we get autobiographical understandings of people, and we get some sort of richer picture of the psychological experience of being sick. So one way of trying to learn about this is to read the work of Anselm Strauss and all these others in the bibliography that I can provide. And another way is to read autobiographies of people who have been sick. And it's a very popular genre. If you go to Amazon and search autobiography of illness, there'll be hundreds and hundreds of autobiographical accounts of illness. And they're a very rich resource. In many ways, you learn more from those than you would from reading the 47,000 or 74,000 articles in PubMed on adherence. Next slide, please. So, I want to talk about this idea of self-regulation. Self-regulation is everything real people do to manage their lives when they get chronically sick. And think of it as improvisation, as juggling. So if you know people are chronically sick, if you yourself are chronically sick, if you're familiar with the lives of chronically sick people, you know that chronic illness poses an enormous number of challenges and difficulties and problems for everyday living. And that to survive, you constantly have to improvise and make all sorts of arrangements and self-regulate both your health, your energy and fatigue, your pain, your symptoms, your everyday work, your family, your relationships, all these things. And so self-regulation, this improvisation, is the default behavior. Adherence, this idea of kind of blindly sticking to being obedient, doing something that someone else says we should do in some static and uniform way, is an unusual departure from normal behavior. It doesn't normally happen. So we should replace this metaphor of adherence with self-regulation, which is the default, this improvised scrambling around to try to survive in the face of all the challenges that chronic illness presents to people. Next slide, please. So here's just the covers of two books that have been extremely influential to me in developing this way of thinking. So the one on the left is called Unending Work and Care. That's the sort of Bible of the trajectory model by Julia Corbin, a nurse, and Anselm Strauss, a sociologist. I cannot recommend this book highly enough. I would say, 90% of what I'm saying in this talk is derivative of what I learned from that book and the articles that came from it. And on the right is another book that influenced me a lot. It's called Good Days, Bad Days by Kathy Charmaz. Kathy Charmaz was a student of Strauss and Corbin's. And this is about the self and chronic illness in time. Both of these are exemplars of this way of thinking that I'm talking about, and I highly recommend them for people who have their interest. So this idea of trajectory is a little bit foreign, and it has a deep and complicated meaning, only some of which will I be able to talk about today. But here's a slide from some work by Adamson and Lynn. Usually depicts this idea of trajectory. So trajectory is just that. Think of the arc of a projectile, through space and time. But in this case, it's the trajectory on the vertical axis here is functioning, on the horizontal axis is time. And in this case, you have sort of cancer trajectory, where you have a long, stable period of decline followed by a short and dramatic decline leading rapidly to death. Next slide, please. Here's a characteristic trajectory for a heart or lung failure, where you have a steady decline punctuated by exacerbations and then recovery, and then followed finally by an exacerbation. Next slide. And this is a frailty or dementia trajectory, where you have a kind of gently sloping, erratic decline, eventually to death. And many of us who have loved ones who are older and have been frail and demented recognize this trajectory. So this is only to give you a visual representation to hang on this concept of trajectory. But one of the key ideas of the trajectory model is that illness is extended in time. And if you can't, and that this ought to be at the center of all of our thinking about chronic illness, the fact that it's extended in time. And a lot of the problem with our models of adherence and lots of other aspects of medical care is that we have acute care conceptualizations we're trying to make chronically ill people fit into. Next slide, please. So these are the defining characteristics of chronic illness according to Corbin and Strauss. I'll go through them very quickly. You can read this stuff on your own. So home is the central site of care. Chronically ill people care primarily about the quality of life rather than the quantity of life. The illness requires lifelong work. Remember, the subtitle of Corbin and Strauss's book was Unending Work and Care. Because when they interviewed and spent time with these chronically ill people, the thing that struck them more than anything else was that chronic illness imposed just incredible, difficult demands on people that required lifelong work to survive and in some cases to thrive. illness moves through phases: acute, comeback, stable, unstable, deterioration, dying. That the work people have to do varies by phase. That there are three kinds of work people have to do: illness work, household work, and biographical work. Each I'll talk about in detail. That people have to constantly make arrangements to survive, and these can be as simple as getting somebody to watch your kids while you go to the clinic, getting someone to shovel your driveway because you can't do it anymore, getting someone to pick up your medicines because you don't drive, all sorts of other arrangements. And these arrangements are unstable, and they vary with the phase of your illness and as the people helping you with your arrangements move in and out of your life or get fatigued. So it requires continuous rearrangement. And the work of health professionals is only part of the overall work. Rather than being at the center, when we have a truly patient-centered view, we realize patients and their homes are at the center. Health professionals are at the periphery, only enter into patients' lives momentarily. Although they're influential, we have to realize they're at the periphery. They're not at the center. And so the real challenge is for health professionals to articulate their professional work into the lives, the dominant everyday lives of patients. And then we have, of course, this concept of trajectory, which I was just talking about. Next slide, please. Please mute your phones. We're still getting a little bit of noise on the line, so we would greatly appreciate it if you could mute your phone. Thank you. So chronic illness is unending work, and there are three kinds of work: illness work, household work, and biographical work. Illness work is taking medicine, doing self-diagnostic procedures like checking your blood sugar, looking for diabetic foot sores, checking your blood pressure, getting yourself to physical examinations or surgery, going for clinic visits, getting x-rays. That's all illness work, the work of the illness itself. And there's household work, which is just exactly what it sounds like. People get chronically sick, they still have to cook and clean and pick the kids up from school, shovel the driveway, raise the leaves, all that goes on. It's just more difficult when you're chronically sick because you're fatigued and in pain and dizzy and tremorous and all sorts of other things. And then there's biographical work, which is really what I want to focus on today, and it's the most unique kind of work, I think. It's the unique contribution of Corbin and Strauss is their elaboration of this kind of work. And that is to say that chronic illness, from the point of view of people who experience it, they experience it primarily as biographical disruption, as something crashing into their otherwise ordinary lives and radically disrupting the flow and story of their life the way they thought it was going to turn out. So illness is biographical disruption, according to this model. And patients, people, what we are primarily motivated to do when we get chronically sick is to try and recover the life that we had before we were sick, and to try to rewrite the story of our lives so that it has a happy ending, or at least so that our life has meaning and purpose after the illness. Next slide, please. Oh, so this slide, at least as I'm seeing it, got a little bit distorted, but I think you ought to get the general idea. So this is the BBC. Please mute your phone for students. Okay, so the BBC chain stands for, the BBC stands for Body, Biography, and Conceptions of Self. So I'll take some time to dwell on this idea because of its centrality. Basically, the trajectory model says, this is a model of health, what it means to be healthy in the trajectory model. The trajectory model says we are healthy to the extent that our body, our biography, and our conceptions of self hang together in some stable configuration and sort of mutually reinforce one another. And if any of these linkages break down and this stable configuration of body, biography, and conceptions of self falls apart, we subjectively feel unwell. Now, normally we think about body failure as the thing that breaks this apart, but as I'll show you, any of these links can break. So let me talk briefly about each of these. Biography is the story of our lives, right? It's as simple as that. So the interesting thing about biography is if I were to meet any of you at a bar and start to ask you about your lives, you could easily tell me the story of your life. But the fascinating thing is, you could tell me about the past, that's what we normally think of, and you could tell me about the present, who you are now. But almost all of us, in fact, I'll say all of us, you could also tell me the story about your future. So all of us have this sense of our own biography, this narrative, which gives coherence to our entire lives. And, of course, the leading character in that narrative is us, ourselves. And so we have this conception of self, this idea of who we are, our identity, the sense of ourselves as the leading character in the drama that is our own biography. And then finally we have a body. Our physical body is the medium through which we live out our biography and through which we live out our conception of self. So to feel well, our body has to support our biography and our conceptions of self. And when that falls apart, we feel unwell. And the main goal of the primary motivating factor for people who are chronically ill is to put this BBC chain back together. And I'll try to illustrate what I mean by that. Next slide, please. So health is defined as a stable alignment of body, biography, and conceptions of self. That's what I just got done talking about. So, I might have an image of myself as a college professor, and I had a certain upbringing, and I wanted to be a scientist, and I went to college, and then I became a college professor, and then I'm going to, live a long, happy life and die peacefully in my sleep, right? So that's my biography. And I have a conception of myself as a scientist and as a professor and an intellectual and so on. And I have this body. And my body needs to support both my conception of self and my biographical aspirations. So for me, that means I need to be able to speak, to think, to write, to lecture, to advise students, to read. These are the bodily performances I need to be able to engage in, and any failure in my body that stopped me from doing those things would dramatically disrupt my biography and conception of self. Next slide, please. Unfortunately, this linkage between body, biography, and conceptions of self is incipiently unstable. It's ready to fall apart at any moment. It takes work to keep it together. In fact, what it means to be a person is to constantly do all this work to keep our body, our identity, and our biography together. And so when people say, I'm having an identity crisis, it means that the work to make it all hang together is failing. Next slide, please. This is just my image that I always think of when I talk to my students about the BBC chain being incipiently unstable. I have this image of people spinning plates, that at any moment these plates could come crashing down, and that the only way to keep these plates stable is to keep spinning them. So that's what it's like to be a person. The only way to keep the BBC chain, this configuration, stable and coherent is to keep working. We have to keep doing performances. We have to keep our body healthy. We have to keep rewriting or editing our biography. Next slide, please. So the BBC chain can be disrupted in a variety of different ways. It can be disrupted by disruptions in any of the sort of vertices there in the body, biography, or identity. And I'll give illustrations of each. Next slide, please. So disruption in biography. So first of all, I'll say mostly we think of disruption as coming from body failure. So that's what we're preoccupied with as people with a biomedical orientation. We think people get sick when their bodies fail them. But I want to illustrate sort of the generality of this model in that we can have a subjective sense of not being well when any of these linkages fail. So the first one I illustrate is the disruption in biography. So this can happen when we become unemployed, when we get divorced, when a child dies, or a spouse dies, or even a parent dies, if we fail in school or some important activity. Any of these, because they depart from the script of our well-written biography, right? No one says to themselves when they're writing their own biography, I will have a nice life and then at 43 I will be thrown out of work by a massive recession and I will never get work again. No one thinks that way. So when it happens, it comes crashing into our life as a disruption. Same with divorce, death of children, failure, and so on. So next slide, please. So this is just, I have a lot of these images from Post-Secret. If you don't know about Post-Secret, I highly recommend you check it out. It's this community art project where people send in slides about their secrets on kind of artistically rendered 3x5 postcards, and I've used a lot of them. They dramatically illustrate a lot of the points I'm making. And again, reading Post-Secret I think is probably better to learn about adherence than reading any of those 74,000 papers in PubMed. So this one says, this is not the life I signed up for. Many of us have had that feeling when our life is just not going according to plan. Next slide, please. So the second way that the BBC chain can be disrupted is by disruptions in conceptions of self. I've given several examples here. Our self can be disrupted by coming out, when people come out as homosexual. That the self that they have been presenting to the public prior to coming out, the heterosexual self, and then they come out as homosexual, this massive disruption of self and identity, which is often extremely destabilizing. And sometimes, cause people to get sick, depressed, suicidal, etc. And destabilizes the whole environment around them often. Discovering one is adopted. That was another example I could think of in something that would radically disturb our concept of self. Who we thought we were is not who we really were. Committing immoral acts. So when we commit an immoral act, we look at ourselves and say, oh, I'm not the person who I thought I was, because we thought we were a certain person who wouldn't commit immoral acts, and then, lo and behold, we commit an immoral act, and we're not who we thought we would be. So these disrupt our concept of self. Next slide, please. So here's the classic form of disruption, and that's disruption due to body failure. This is what we normally think of when we think of illness. This is biomedically what we normally think of. We think of the body as a machine, illness as a breakdown in the machine, and so on. But we'll see that within the context of the trajectory model, it's just one of many kinds of disruption, and that body failure itself doesn't have significance unless it ripples out into and disturbs biography or conception of self. So here's all the many kinds of body failure: paralysis, tremors, limps, memory loss, slurred speech, scars, sores, deformities, the whole litany of body failures. There's many more. Next slide, please. So, illness manifests itself in our lives as body failures that destabilize the BBC chain. Notice I didn't say it manifests in our lives as body failures. In fact, body failures have no significance to most people unless they destabilize either our conception of self or our biography. So that's why people can live for years with what we think are very peculiar body failures. So we'll always read about, the example I give to my students is people who have very, very large cysts, benign cysts. These can often grow to epic proportions. And yet people come to the emergency room often with cysts 10 pounds, 20 pounds, causing obvious physical deformity. And the doctor will ask the patient, well, didn't you notice? And they'll say, well, at first it was just a little bump. And, it didn't really stop me from working, and my wife didn't mind, and so it didn't disrupt their sense of themselves, it didn't disrupt their biography, and so they had this peculiar body failure happening, and maybe it was a little blood in their stool, maybe it was a little lump in their breast, but the body failure itself has no significance unless it destabilizes the BBC chain, meaning unless it gets in the way of being who I am and living out the story of my life the way I want it to go. And I think this explains a lot of the illness delay that we see, is that people don't come in to seek care until the body failure actually is disrupted to the BBC chain. Next slide, please. So, we want to understand people. I think from a biomedical point of view, a lot of the behavior of people who are chronically sick seems totally paradoxical and perplexing. So people come to us, they subject themselves to painful and embarrassing procedures, they pay a lot of money for tests and visits and then medicines, and then they go home and they don't do anything that we say. And this puzzles us because we totally misunderstand what it's like to be sick. We're under the mistaken impression that what it's like to be, that people who are sick really want to get well, where well is defined as all of their biomedical parameters within normal ranges, or well being defined the way the doctor would define it. But this just isn't reality. What people are really motivated to do is to keep this stable alignment between body, self, and biography. In other words, people are just motivated to be the people that they are and to lead out their lives the way that they've, written this narrative for themselves. And the stuff about being objectively healthy the way biomedicine defines it doesn't really come in, or again, only comes in at the periphery, but it's not central. Next slide, please. Next slide, please. So, how do people maintain a stable configuration between body, biography, and conceptions of self? And by any means necessary. That's how they do it. This is the critical motivating force, in my opinion, behind people who are chronically ill. So they will do anything necessary to keep body, self, and biography hanging together in a way that makes them feel well. Next slide. So, it leads me to a very, very simple model of adherence. Even though I don't like adherence. So, if the regimen, whatever it is, helps to stabilize the BBC chain, then a person will follow the regimen. If not, then not. I couldn't put it any simpler than that. So the regimen has to always be seen in relation to the challenge of keeping the BBC chain together. If the regimen helps, people will be eager to use that help because it helps them achieve their prime objective. Remember from Star Trek, if any Star Trek fans, there's the prime objective, the prime directive, I'm sorry. And the prime directive for chronically ill people is keep the BBC chain together. Anything that helps, they'll happily take that help. But if it doesn't, then it's just a distraction. Next slide, please. So there's a problem. And the problem is that regimens cause as many problems as they cure. And in particular, they cause body failures. The regimens cause, but they both cause and cure body failures. So when the whole idea is to minimize body failure so as to minimize the disruption in identity and biography, when we start introducing regimens that themselves are body failures, we shouldn't be surprised that people don't take them, especially when the illness itself caused no body failures, it was asymptomatic, but the treatment causes identity-relevant body failures. Then this theory predicts, or tells us not to be surprised. Next slide. So here again is another image of secret. This is an example of how medicine causes a body failure and doesn't help. So it says, taking these didn't make me any less depressed, and you can see the citalopram, but they did make me shit myself in church. So this is obviously an identity-relevant body failure. No one wants that to happen to them in church, but this individual, that's what the medicine did for them. So should we be surprised if maybe they discontinue this medicine? Next slide, please. Here's another postcard from Post Secret, and it says, I stole this postcard. My bipolar meds stole my art. And again, I just use this to illustrate how medicines have identity-disrupting effects, that medicines have extreme consequences for identity and biography, and people will reject them for this reason. Next slide, please. Here's yet one more. So this is a positive one. This is, I waited 43 years to get on antidepressants. I love life so much now. I use its name for my computer password. So I don't want to, it's obviously the case that medicines sometimes cure body failures and restore a stable and preferred alignment between body cells and biography, and this illustrated here. Next slide, please. Well, the basic mechanism that we want to understand, or that the trajectory model asks us to understand, it goes something like this when we think about physical illness, at least. So it begins with body failure. The body failure, whatever it may be, I gave a long list, causes a failed performance. The failed performance causes loss of self, and loss of self is what causes suffering. So let me backtrack a little bit. So the sociologists that came up with the trajectory model were interested, they based their thinking around this dramatical metaphor of human life. That is, they thought the world is a stage and we're actors on this stage. So they used words like role and identity, that we would use in a dramatic context, and performance. So the idea here is that in order to maintain a self-image in the world, we have to engage in performances. So I'll use myself as the example again. I think of myself as a college professor. That's my identity. That's my identity. But in order to maintain that identity, I have to give lectures and grade papers and publish papers. And those are the performances that actually constitute my being a college professor. So if I said I'm a college professor and someone said, what do you teach? I said, oh, I don't teach. Well, what do you write about? Oh, I don't write anything. Well, what do you do research about? I don't do any research. Well, then I'm not really a college professor. It's in the performances that my identity actually exists. This is true of all of our identities. All of our identities depend on certain performances for their enactment. And when we can't perform, we lose those identities. And many of us who have been sick, or I think of the Paul McCartney line, suddenly I'm not half the man I used to be, right? We get sick. We're not the person we were before because we can't do the things we did before. And because we can't do the things we did before, we can't be the person we were before. And because we can't be the person we were before, we suffer. And so this is the trajectory that I want people to think about. So we obviously want to help people, we want to short circuit this either by stopping the body failure and minimizing the failure by minimizing the certain performances are much more important than others. There are many things I do in my life. I give lectures, I read and write books and articles. I also do laundry, right? So laundry, although it is relevant to my identity as a father, I couldn't do laundry anymore. It wouldn't break my heart. It wouldn't massively disrupt my identity or biography. But if I couldn't lecture anymore, or read articles anymore, or do research anymore, my identity would be dramatically disrupted. And think of, I think of this woman, Rachel Barton, this famous violinist who suffered a tragic train, very badly injured, and suffered a partial amputation of one leg. But because she was a violinist, her hands and arms were relatively unscathed by this accident, and she was able to continue playing the violin. Since violin playing was the most central performance of her whole identity, her recovery was better than it would have been had even just a pinky or two fingers been lost rather than a whole leg. So some performances are much more relevant than others, and that's why we can suffer some kinds of body failure with almost no impact on our identity, because some performances, with some parts of our body we frankly don't need to maintain our identities and biographies. Next slide. And it's different for each of us. So body failure only has biographical significance if it impedes an identity-relevant performance. So again, for me, if something were to happen to me, if I developed a profound allergy to laundry detergent and I couldn't do the laundry anymore, it would hardly affect my biography at all. Or let's say I hurt my knee very badly and I couldn't run anymore. Well, I don't run as it is, so that's not a performance that's important to me. Losing the ability to run wouldn't really affect me. But on the other hand, there are many other, I'm a guitar player. If something were to happen to my hands, it would dramatically alter my biography. And this is true of all of us. I do an exercise with students where I ask them to write down what are the most central performances in their life. And it's not a difficult exercise. All of us can think of those things we do in the world which are most central to the maintenance of our own identity. And it's only when those things are affected by body failure that we feel this disruption. Next slide. So this is an example of how our performance. So this is from Post-Secret again. It says, my depression skews my data. I feel like a bad field biologist. So in this case, this guy's depression altered this performance that was central to him. But depression impeded that in some way. And it was, you can see yourself in this picture, what it did to the person. Next slide, please. So those are classic examples of body failures, which I think go to the heart of identity-relevant performances. And the worst one in the world that I can think of, there are many dread diseases, and in many ways this is not the most dread disease. But this is a disease that seems to target the most identity-relevant performance in a person's life and go right after it. I don't know how many people on the call have heard of focal dystonia. I encourage you, there's a great Wikipedia page on it. But dystonia is obviously a malfunctioning of the muscles. Focal dystonia means it's a specifically focused malfunctioning of the muscles. And the way I came to know about it is because it affects musicians. And what it does is it normally affects musicians right where they need it most. So a musician doesn't get focal dystonia of the feet normally. They get it of the hands that they need to play piano. There's a very famous concert pianist that got it. Many, many musicians have gotten it. I knew of a weatherman who spoke for a living, had focal dystonia of the tongue and couldn't speak clearly. So overuse and repeated disciplined use of certain muscles seems to actually cause this focal dystonia sometimes. But what it does is there's like a bullseye around that performance which is most central to your identity, and it disrupts it. Next slide, please. Example of vocal fold bowing becomes an example from my own life. I suffer from this malady called vocal fold bowing. I've been speaking my whole life. I was on the speech team in high school, gave the speech at my high school graduation, and then I got a bachelor's, master's, and Ph.D. in speech communication. Then I became a college professor, and I talk all the time. I was hoarseness in my voice was sort of going out on me. Next slide, please. And that's a picture of my vocal cords. And if you know anything about the larynx, your vocal cords should touch. And mine don't. There's this bowing. There's this space in my vocal cords. And it causes this vocal dysfunction and vocal fatigue, so on. Even as I'm giving this seminar, I have to drink a lot of water so that I can get through the whole thing. So this is a very identity disruptive malady for me to have because speech is so central to my identity. Next slide. So there's me in the office. The reason this picture was on the chart where the pictures of my vocal cords were, and I saw it, and I looked so scared, and I looked so vulnerable. I don't like to think of myself looking that way. And in fact, I didn't feel that scared, but I thought it was just illustrative to think of, well, this is what being a patient does to us. It humbles us, and in many ways, we should be being stick a tube down your nose. Next slide, please. So loss of self is the fundamental form of suffering in chronic illness. That's what it boils down to. Not being able to be the person who we want to be. That's where the actual psychic suffering, the existential suffering, comes from not being able to be the person we want to be. Next slide. This is a Post-Secret slide to illustrate this. I'm so scared that I will never again be the person I was before I got sick. I miss her. Nothing could encapsulate what I'm trying to say better than this one postcard. This woman experienced the loss of self and is suffering because of it. Next slide. About alternative treatment. Smoking weed has helped me remember who I was before I developed a mental disorder. Again, I use this postcard because it references this notion of loss of self, the idea that who I am now is different, and less than, worse than who I was before I got sick. Next slide. Again, I think I have breast cancer, but I won't tell anyone because I don't want to be the sick girl. So there's some stigma. This idea of loss of self can be traced directly back to Irving Goffman's great little book, Stigma, and the idea of stigma, which is to have a spoiled identity, to have a stain on our identity. Next slide, please. So this is another post-secret slide. I hate that cancer is a fight, but infertility is a loss. And again, I'm just using this to illustrate the idea of loss of self. Next slide, please. So in the context of all this trajectory model stuff, medications take on a very particular sense. And in fact, what comes to be important is what medications mean to an individual person in relation to their identity and biography. Their dosage form, their strength, their route of administration, their indication, their list of side effects, their mechanism of action, all these other biomedical meanings of the drug are largely irrelevant. The only thing that matters is what is this medication going to do to me in relation to my ongoing struggle to keep the BBC chain hanging together. Next slide, please. So here's another post-secret slide to illustrate. I'm scared the antidepressants will change who I am, and no one will like me anymore. So this is a classic illustration, and David Carpenter's written whole books about this. A classic illustration of how medications disrupt our identities, and psychoactive medications are especially notorious for this. And people will resist them for exactly this reason, even if they work. In fact, especially if they work. People don't want to believe they have a lifelong mental illness. If they take an antidepressant and it works, then they're led to that unavoidable conclusion. So many people avoid these medicines because it might work and alter who they are. Next slide, please. Here's another one. This is metformin prescriptions. If this pill could change my whole life for the better, I won't let it because I'm scared. Part of me thinks I don't deserve it. So here, what I'm trying to illustrate is that the decision to take a medicine is intimately and inextricably tied up with thoughts about who I am, who I want to be, who I deserve to be. In other words, that the meaning of the medication is inextricably tied up with identity and biography. And the decision to take it is a decision about identity and biography. It's not some biomedically grounded decision. Next slide. This is another one. You know what scares the hell out of me? The fact that my sanity is subject to the mercy of words and symbols scribbled on a prescription pad. Next slide, please. Another one. I'm terrified I'll come out of the closet when I'm anesthetized. So here's this incredibly, the fearing is identity disruptive. Here, the coming out, which I said was a conception of self disrupting thing, and medicine, these things intersect exactly. They're afraid that medicine will cause them to out themselves and disrupt their identity and biography in this dramatic and undesired way. Next slide, please. So the question, this is the way I like to boil it all down in terms of medicine. To take or not to take the medicine is a decision to be or not to be a certain kind of person. It's an existential decision. You look at that medicine and you're trying to decide, am I going to take it? Am I going to, because as soon as you take it, you go from being the normal person you were to being the kind of person who takes that medicine. Because that's a leap many people don't want to make. It's a change in identity many people don't want to make. Next slide, please. Yeah, I got it. So is it me or my meds? This is the question. Once you start on medications and you start to feel differently, then you don't even know what's authentic anymore. And any changes you might experience in your sense of yourself or your biography or your identity or your body, you don't even know. But David Carp wrote this beautiful book. This is about the experience of teenagers on psychoactive meds who continuously ask themselves, is it me or my meds this way I'm feeling? Next slide. So the challenge, I'm going to get away from the sort of pure conceptual stuff and start to think about what we might do if we took the trajectory model seriously as a way of thinking about patients' self-regulating regimens in their lives. The challenge is to build and test interventions based on the trajectory model. Next slide. And the best example I like, and these guys wouldn't say that they were building this based on the trajectory model, but it's the organization of care. This is the Improved Care Now network that folks at Cincinnati, Michael Sade and others at the Cincinnati Children's Hospital are developing. And I think it could be used as an exemplar of how we might reorganize care if we really put the patient at the center in the ways that I'm talking about. Not that they would necessarily endorse what I'm saying, it's more me endorsing them. Next slide, please. So some directions for research and some hypotheses. Effective self-regulation will be positively associated with the extent to which a regimen restores or helps to restore or maintain the integrity of the BBC chain. Remember, the BBC chain is the core of everything. Regimens that help you restore or maintain the stability of the BBC chain, people will follow them, otherwise they won't. But in order to test a hypothesis like this, you need measures of the integrity of the BBC chain, measures of the success of biographical work, measures of the identity relevance of body failure. And we don't have this because all the people who did this work are doing ethnographic work. They don't design questionnaires. That's just not what they do. Next slide, please. So some particular hypotheses. Regimens that cause identity-relevant body failures will not be integrated into self-regulation. That's what SR stands for, self-regulation. Regimens that repair identity-relevant body failures will be integrated into self-regulation. Regimens that support or restore the stable alignment of the BBC chain will be integrated into self-regulation. regimens that cause a destabilization in the BBC chain will not be integrated into self-regulation. This is 4 different ways of saying the same thing, basically. Next slide. So this way of thinking about adherence and body failure and medications and their meaning, it has some interesting implications, and this is one of them. So the same side effect or the same intended effect will have differential effects on different people, depending on and have differential effects on whether the regimen is incorporated into self-regulation, because the identity relevance of the side effect or the intended effect will differ from person to person. So we can't think of side effects without also thinking of the way they intersect with body failure and identity. And a good example of something like this is think of antidepressants. Many antidepressants cause sexual dysfunction, either inability to get an erection, inability to achieve an orgasm, sometimes both, loss of libido. And other antidepressants cause weight gain. So sometimes you can have a patient sitting in front of you and say, look, take your choice, loss of libido, loss of orgasm, or weight gain. And some patients will be able to make that decision very clearly because of the identity relevance of either their sexual potency or their body image. Next slide, please. So understanding the identity relevance of the regimen effects, it should predict whether the regimen will get incorporated into self-regulation. But to understand the identity relevance of these effects, we have to understand something about our patients' identities and biographies. If you take the trajectory model seriously, there's absolutely no way around it. This is an unavoidable conclusion. We have to understand something about our patients' identities and biographies, or else we will not understand why they're making the decisions they are. Next slide. So for each illness and for each regimen, we need to kind of catalog the body failures that the illness causes, the body failures that the medicine causes, and the body failures that the medicines might treat. Next slide, please. For each patient, we need to know how those body failures map onto their identity and biography. Next slide. And then we need to somehow plot a course of therapy that minimizes identity-relevant body failure, that allows them to engage in their identity-relevant performances, and minimizes disruptions in the BBC chain. That's a regimen people can follow. Next slide, please. But even this is too biomedical, because we need to focus more generally on all disturbances in this chain. I've been focusing mostly on body failures, but that's a biomedical bias to focus on the body. As I illustrated, the BBC chain can be disrupted by disturbance in identity, disturbance by much. Next slide, please. Even if we have this model of motivation, that is, what are people motivated to do? Namely, they're motivated to maintain the stability of the BBC chain. They're motivated to be themselves and live out their biography. So that's their goal. But we still need to understand who are these people? What are their capabilities? In pursuing this goal, what kind of attention, memory, perception, reasoning capabilities are they equipped with in pursuing this goal? And that's where we need a kind of accurate, modern model of all these cognitive skills. Next slide. So here, this is the slide I call tongue-in-cheek revenge of the social sciences. So as I was thinking about this, I was contrasting what I think is this implicit model that's built into all this biomedically oriented adherence research and the model that I think we ought to have. And here I have this comparison and contrast of all these characteristics. And I'll be the first to admit, I'm using hyperbole, I'm exaggerating some of these distinctions, but I think most of these distinctions are real. And I'm drawing these distinctions more sharply than they are in real life for the purpose of illustrating the main point. So on the left we have this biomedical man, Homo economicus, so-called economic man, this perfectly rational person. On the right, what I call reality man, or Homo veritas, Homo sociologicus, maybe. So on the left, you see all these characteristics out of law. We use rational choice theory or expected utility theory to make decisions. We have a normative model of their reasoning. They're logical. They value normal biological functioning above all. The heroes of this way of thinking, Descartes, Newton, Watson, Crick, Pasteur, von Neumann, Parsons, etc., they reason well about probabilities. But on the other hand, reality man, which is what I would argue modern social scientists tells us people are actually like, is that they have bounded rationality. They're not that rational at all. They use prospect theory, which is this modern theory of decision-making, rather than expected utility theory. It's a descriptive model of how people are, rather than an ideal model of what we'd like them to be according to Aristotelian logic. That we focus that they're psychological rather than logical. That they value the stability of the BBC chain above all. The heroes are Kahneman, Tversky, Corbin and Strauss, Erving Goffman, Leventhal, Herbert Simon, these people who developed these sort of my heroes of social science. The reasoning is influenced by heuristics and biases. Next slide, please. More of these distinctions to try to understand. So on the left, again, is this implicit model but I think underlies the way we think about adherence that we should get rid of and adopt this model on the right, which I think is the more social scientifically accurate model of what people are actually like. And again, with the caveat that, I'm using hyperbole for the purpose of dramatization. And no, if you tried to pin down any particular adherence researcher, they wouldn't necessarily claim to, subscribe to all the beliefs I'm attributing to them on the left. Nevertheless, I think you can find evidence of it in the way they approach these problems. So, again, reason versus emotion, neoclassical economics versus behavioral economics. You have, on the biomedical side, a largely unexamined, normative, taken for granted, implicit model of human behavior and decision-making. And on the other side, a kind of scientifically developed, tested, descriptive, predictive model of human behavior and decision-making. On the left, motivations of patients' preferences are extrinsic. They're actually not part of any of the theory. They're just sort of assumed to be given. Whereas on the right-hand side here, motivation is what we want to study. We want to understand what people are actually motivated to do and why. On the left, we sort of have this idea of obedience or submission. It's inherent in these words: compliance, adherence, following orders, following regimen. And on the right, we have this notion of self-regulation, which is a much more independent of any notion of obedience or anything, but it relies instead on this idea of improvisation. On the left, the social, psychological, cultural aspects of people are treated as exogenous to our concerns, external, given, taken for granted, or not my job, is the way I typically think of it. When I'm teaching pharmacy students or medical students, I think of all these issues, social, psychological, cultural aspects of people's lives, not my job. Maybe the social worker's job, the clinical psychologist's job, but not my job. And on the other hand, these aspects of personhood are the objects of scientific inquiry in this other way of thinking. And on the left, we think of drug action in mechanistic lock and key terms. On the right, we think of drugs as symbolic, semantic, hermeneutic, having meaning primarily. Next slide. Get more of these contrasts. The biomedical man thinking about the acute sick role as the prototype for what patients' lives are like, with the body as the focus, and scientific models of disease, contagion, and the development, and so on. And on the right, the trajectory model instead of the sick role as our underlying model of the experience of illness, chronic illness as the prototypical form of illness rather than acute illness, the person as the focus rather than the body, and common sense models of illness rather than scientific models of disease. Next slide, please. So I think these poor rates of, quote, adherence are emblematic of this larger failure of the biomedical worldview. And again, as with almost everything I've said today, I'm not the first to say this. You could read this George Engel article, The Need for a New Medical Model, which is about 35 years old, making some of these points and been made over and over again for a long time since. But I think that the reason we just don't make any progress is because we're attached to the wrong implicit model of people and the wrong way of thinking about what it's like to be chronically sick. And until we change that, we'll continue to spin our wheels. We'll publish 74,000 more articles, and it will amount to all sound and fury signifying nothing. Next slide, please. So there are these revolutionary developments in sociology, cognitive science, but they've largely failed to penetrate biomedical education and practice. I've been jousting at these windmills for a long time myself with only limited success. It's very, very difficult, although there's very little room for it. And I teach at a college of pharmacy. I get 2 hours of required coursework in their entire 4 years of didactic training. Most of my students think that it's irrelevant to their biomedical concerns and to their lives. And I've been fighting that battle a long time. It's the same for many of you. If you work in medical schools, you know exactly the sorts of battles I'm talking about. So I think we might think, oh, well, the answer is we just need to train physicians in the trajectory model, and then everything will be okay. But I don't think this is the answer. I think that physicians are unlikely to ever master the modern social science that I've been talking about and modern biomedical science at the same time. It's just too much. They can barely master the biomedical science that they need to master. It's totally overwhelming, and it's no fault of their own. But the idea, it's as likely for a practicing physician to master all this social science as it is for me to master all the biomedical science that they've mastered. Just on the sideline, in addition to my regular career as a social scientist, I'm also going to master all the biomedical science that a physician knows. It seems just vanishingly unlikely. I just don't think it's going to happen. Next slide, please. So that means physicians aren't the answer. And the implications are, when I first gave this talk at the HRQ annual meeting, I had a very pessimistic view. And in some ways, I still have a pessimistic view. The implications are, unless we radically reformulate the way we think about people being sick, and then reshape the system to take care of them in this different way, I have very little hope that that we will make dramatic changes in quote, adherence. In fact, I would predict the situation will go on exactly as it does, which is marginal improvements in adherence, focus on superficial problems in adherence like forgetting or cost, which we see when we fix forgetting or when we fix cost as barriers. We get tiny incremental improvements in adherence, but are often not what we would expect. They don't get you from 50% to 90%. They get you from 50 to 53 or 50 to 55% adherence. So the implications are, we need a radical rethinking and a radical reshaping. Some of that's going on because of the changes happening in our system now due to cost, but it's challenging. And I'd love to hear from people. Please email me and tell me you have a much more optimistic view and what that view is. Next slide. I think something like the Improved Care Now Network gives us an example of what we might do. So some caveats. There's still many, many important problems in adherence that I didn't talk about, traditional problems that I care a lot about, but I didn't talk about. Health literacy being a major impediment to any adherence because if people have no idea what the medicine's for or how to use it, in spite of their motivation, they won't be able to use it accurately, and I mostly talked about motivation today. Many, many millions of people don't have access to medicines that they might well take that might improve the stability of their BDC chain. There's lots of acutely ill people, and I've focused on almost exclusively on chronic illness because it's the more important problem from a systems and societal point of view, but there's still, with 25% of the people are acutely ill, 25% of the costs or whatever are on acute illness roughly. And then there's this difference between intentional and unintentional non-compliance or non-adherence. I focus mostly on the intentional kind. The unintentional obviously exists and is important. Next slide, please. So that's it. I got it on 61 minutes. This is a summary of my main points. I won't go over them. You can read them yourselves. I don't know whether there's opportunity or inclination, whether we're going to take questions now or just email questions, or I think Dr. Lambert had a question.
Well, we have one question. Sorry. And I think that Dr. Lambert already answered it. Is there really room for ethnographic trajectory research in the positivistic, quantitatively, economically driven healthcare? And I think that Dr. Lambert gave his opinion on that answer. And I think that, we're all here doing work in this area, and I guess I would be more of an optimist. That I think there's a lot of factors shaping this. We have many, many efforts now and in play to rethink the healthcare system, rethink pay-for-service model that we've had, and to rethink adherence into a way that makes sense for patients and for healthcare systems. So with that, I really would like to thank Dr. Lambert. This was the first of the NIH Adherence Network a Distinguished Speaker Series. Please join us for our next one. We will be sending out announcements shortly. Thank you.
I'm sorry for interrupting that. And please, email me, lambertv@uic.edu if you have questions, comments, great thoughts. If you want a copy of my syllabus or a biography of the kinds of readings that went into this talk. I think at some point we'll make the slides available as well, at least a version of the slides. So thank you for your attention. I really appreciate you sitting and listening to me talk for an hour.
Thank you.